We'll just wait a couple more minutes until everyone arrives.
Good.
Okay, well, I might make a start. So thank you. Can everyone hear me clearly enough?
Yep.
Yep, great. So welcome to today's session. We've got growing primary health services in your organisation.
Alicia, do you want me to start?
I will start right now. There we go.
That's all right.
There we go. Start with an acknowledgement of country. I wish to acknowledge and to pay my respects to the traditional custodians of this land. I pay my respects to their elders, past, present and future. I'd also like to extend my respect and acknowledge any Aboriginal and Torres Strait Islander people that might be present here today. Thank you. My name is Alicia Brown. I'll be your host today. I'm a Regional Services Officer and I'm located in Bass Coast, South Gippsland region. I do cover all of Gippsland though. Okay, so just a few tips. If I may, please ensure that throughout today's session that you are muted. If you wish to ask any questions, you'll notice that I've just popped a little reminder in the chat function there. Please feel free to ask any questions in the chat function. Please feel also free to just let us know what you'd like to get out of today's session, so that will help our presenters. There may be topics that will be covered in today's session that will address that. There may also be the topic that will be covered in the later session, so session 2 that's also coming up. Hey, I'd like to introduce today's hosts. I have got from Kofi, or the community-owned primary health enterprises, I've got Rod Wilson and Chris Love, who are the directors. COFI is a service which aims to support communities and not-for-profit organisations to develop and run their own health services. COFI works with organisations to increase their understanding of how the primary healthcare system works while exploring innovative, alternative models of primary healthcare delivery and funding. COFI also works with organisations to develop sustainable service and funding models for primary healthcare services. So I'd like everyone to welcome them. Thank you. If you'd like to share yours, thanks, Rod.
No worries. I'm getting there. There we go. Terrific. So you can all see that and hear me. Is that okay, Alicia? Cool. Okay, so just let me see this. So thanks so much for coming along today, and we really appreciate it. So Chris and I, just by way of background, I've been CEO of a number of community health services in Victoria and a Medicare local, and have had quite a lot of experience in both initiating and creating primary healthcare services. Chris is more focused on the financial modelling side of things, and we're going to be working through from a kind of macro view of the world to a micro view. We're going to drill down into some detail, but we're going to start off with at a much higher level in terms of the primary healthcare service overview, about the different levels of government and how the funding works, a bit about primary healthcare in Gippsland, where Chris and I have done a lot of work for the Gippsland PHN and are very familiar with quite a lot of the services that operate in Gippsland. We're going to talk about what a best practice public-private integrated primary health service might look like. Chris is going to talk about creating a self-funding primary health services. What would that look like? And how does an MBS work? How you can make it work more effectively. So feel free to put things in the chat room. And Alicia, if anybody asks something that's relevant as we go along, or even if they ask something that's irrelevant, you feel free to interrupt us, and we can see if we can answer those questions. So I'm going to start from the macro, and this first session we're running today, we're going to hold these over 2 sessions, and we'll finish at a certain point in today's session, which will be a precursor to drilling down into more detail about how you can actually, the really critical things around the financial and service modelling for your organisation. So just to give an overview, and a lot of this are things that you will know. We have quite a good health system in Australia, done a great job with the pandemic, which is fantastic, despite the fact I haven't been able to go to a cafe for a long time. But anyway, despite that, still Australia's done a great job. The issue is inequity of health outcomes, poor access for specific groups. And a lot of that is also city versus country kind of stuff, and particularly Indigenous communities. We have a very hospital-centric health system, and that's one of the reasons why Chris and I are interested in this whole area, because the counterbalance to a very hospital-centric system is to have a much stronger primary health system. But how do you create that? And it's not straightforward. You know, these issues of an ageing population, chronic illness, mental health, suicide, etc. And we've seen with the pandemic response has exposed, again, the issue between Commonwealth and state relationships. And I know the Gippsland PHN have been in the middle, and with some support from us in a small way about developing the respiratory clinics and the role of the public sector and the role of the private sector in all of that. And so we've had, of course, less in rural, but much more in city areas, an increased corporatisation of primary health care and a corporatisation of aged care. We've all seen the Aged Care Royal Commission and what's come out of that. And NDIS is kind of heading in a similar way. So we'll talk a bit more about that. The main funder of primary health care however, is the MBS. And so your average GP practice, a lot of allied health, a lot of mental health is funded through MBS. And we're going to dwell quite a bit on that. The problem with Medicare is that it follows the providers. So if the providers want to set up in a particular area, that's where the money goes. And we've seen in Gippsland a number of notable cases where the GPs have threatened to leave town, and we've had discussions with the PHN and with advocacy bodies saying, well, why should the money for MBS leave town when the GPs decide to leave town? Why can't the money stay there? Well, we know why the money can't stay there, because that's not the way Medicare works. But it seems unfair that the dollars follow the provider, and if the provider doesn't want to work in a particular place, then there is no service. And that's pretty clear in Gippsland. So GPs are still the main game. So GPs are the cornerstone of the system, and we'll get to that. So the trends, policy directions, we're still retaining a kind of fee-for-service marketised competitive system. NDIS, My Aged Care, MBS, all leads us to think about a business model. So there are grants, and we'll get to what the PHN funds a bit later on in this presentation. There are grants, but predominantly where primary healthcare is working off a business financial kind of model. So increasingly for providers such as yourselves, understanding that business model becomes really important, and it becomes really complex. So again, that's what we want to talk about in this through these sessions. So NGOs, community health services, and others are accessing some of this funding. You will see in your own throughout Gippsland, and they're behaving more like a business. So even your NGO sector is becoming slightly more. You've got a couple of notable inclusions in Gippsland where the community health services look very corporatized, and are figured out how to run a business model, and good on them, and they've grown their business as a result. So, but what does that mean for localism, for effectiveness in some communities? So also these things, all of these areas, MBS, etc., they can also not just fund GPs, of course, they can fund allied health and mental health services. So that's a really critical factor, but how you do that is tricky. Some of you will already be doing that in different ways, but to build that capacity to fund allied health and mental health is a critical thing. So again, GPs have become, I would argue, more marginalised, and certainly in very remote areas. You've got some communities in Gippsland which could have 3,000 or 4,000 people but no GP service, and then you might have a community of 1,000 people that's actually got quite a robust, or at least it's a survivable GP service. So you've got this mix and matching. So they've become quite marginalised, and I think GPs feel marginalised when it comes to a lot of other parts of the health system. Telehealth has helped. A lot of GPs and other practitioners are now using telehealth. Initially, that was a big problem. I think now a lot of medical practices and other practitioners have figured out how to use it, and it's kind of bounced back. So obviously, COVID has had long-term impacts. There's now a switch towards the funding of public health. So obviously Victoria wasn't exactly a star when it came to rolling out the contact tracing and stuff like that. So there's a much bigger focus now on that. Obviously social determinants, still a major issue. The fact is that, a lot of the things that cause poor health are well outside what a clinical service model can address, but it's still important for that to be within the paradigm. But there is a need to increase the interface between the different sectors, and that's particularly the private and the public sector, the average medical practice, and the NGO sector that are providing services for very marginalised communities. How do you join this up when they're working off such different kinds of financial models and business models? So the government and PHNs, and part of the reason we're doing this seminar today is that, you know, PHNs are in the business of trying to address market failure. They're trying to build the capacity of services that might be more marginalised to do better. And market failure is most conspicuous in small rural towns where the MBS funding model doesn't work well. So you're all providers in some part of the system. And so we've just done this very rough, arbitrary kind of map just for you to have a look at and say, well, where do I fit in that service model? But because it's conceptually, even if you're an aged care provider, increasingly you're more in the healthcare provision business as well. Or if you're an NDIS provider, you're also partly in the healthcare provision business. Hospitals now no longer see themselves as just hospitals, but health services doing a lot of stuff in the primary health area. And community service providers are working with a target group that really needs good access to primary health services. So you've got this system, roughly called a system, which is trying to, where we're all a part of it, and which needs to be joined up. And how do you join that up? In the interests of certainly the most marginalised and the people with most ill health. So yeah, most providers fit into one of these spots, private, public. Most purchasers, like the PHN, like state government, are trying to address the very disparate silos that actually exist. So how do you overcome that highly siloed service model between drug and alcohol, mental health, chronic illness, etc.? The funding tends to come in silos, and whether it's through MBS or through grants or whatever. So there's a best practice model would be a fully integrated model. We'll come in a minute to what looks like, what would be in a best practice primary healthcare team. And part of the reason why we're talking about growing these services is so that you know, providers can think more about how you actually build your team. How can you get your hands on the resources to become a more integrated service model? And I'll describe that in a moment. So there's integration enablers like funders, planners, academics, providers. A lot of providers are working hard to develop these integrated service models. There's barriers to integration, which is, you know, a high level of privatisation, corporatisation, the silos, you know, the competitive tendering that people are forced to do. It's very hard to compete with another organisation for funding and then expect them to behave like their best friends after one of them has won the tender. So, yeah, people often say, but there's no money in healthcare. And this is just a graph that shows you that actually there is really a lot of money in healthcare. You may not be able to get your hands on it at the level you want to, but there's a lot of it out there. So something like 10% of GDP and $185 billion, you know, so a lot of this is in very different sections. A lot of it goes to hospitals, et cetera, et cetera. I won't go through the detail of that, but I think there's something like 25 billion in Medicare dollars. Chris, you'll correct me later if I'm not right. But anyway, And so just coming back, the final bit about the contextual stuff before we get into some more detail, is the Commonwealth says it's responsible for primary health care. And the PHNs are really a product of the Commonwealth government. And they are, in a sense, you know, the planners and partly the funders of primary health care in local areas. But, you know, I don't want to lock the PHN into this view, but in my view, there really isn't much of a plan, and there's certainly no plan at the state level. So, you know, the PHNs have to create their own plan and their own, within certain frameworks, which the Commonwealth, I'm sure, would say they have. Anyway, none of this has to be owned by the PHNs, just my opinion. There you go. And clearly reform of Medicare is needed. I think that's well known. Anyone who tries to work in a small practice in a country town knows that Medicare doesn't work. It's a market-driven funding formula, and we've talked about some of these things. So, you know, increasing out-of-pocket expenses disadvantages the poor, silo purchasing. You know, obviously public dental is one of the major gaps. So just looking at Gippsland for a moment, this is a sort of snapshot of the services within Gippsland. You've got a population of, I think, 280,000 or so across Gippsland. You've got 84 medical practices that service that population. So, you know, you've got a very mixed model of medical practice service delivery. So obviously larger, bigger ones in the big towns, big rural areas, and in small, remote areas, they really struggle to survive. And so if you divide the population into that number of medical practices, it's an interesting effort to make sure that there is an adequate spread of basic primary health services in Gippsland. There are 2 big community health services. There's 5 large hospitals, a number of multi-purpose services. There's NGOs, community service providers, including NDIS aged care, etc. You've got private allied health and private mental health. You've got many pharmacies and many pathology providers. The reason I present this is actually what is in, you know, partly what is in Gippsland, is that it's a very disparate range of services, and they are more or less integrated, depending largely on personalities. If you've got a good relationship with your local medical practice, or the medical practice got a good relationship with the hospital, or the community health service gets on particularly well with another organisation, then that tends to fuel better integration. We would argue that leaving it to, I know everything's built on relationships, but allowing that to be the case probably is not such a good thing. A system that actually makes that happen would be far better, given that the vast majority of dollars coming into the system are actually taxpayer dollars. So, so yeah, in Gippsland, you've got a significant hospital system also providing primary health care, community health services that get quite a lot of government funding. You've got waiting lists for public health services. And that's one of the reasons why we like to focus on the MBS stuff a bit, because one way of addressing waiting lists in public health services is to make sure you're making most use of all the funding mechanisms available, which includes Medicare. So what we find is, you know, I'll get to this in a minute, is that the GP sector, the medical practice sector, are not very good at accessing government grants, and the government funded sector, the public sector, are not that good at using Medicare. So you've got two, you know, the GPs are reluctant to put their hand up for a grant for a whole lot of reasons. And we saw that through development of respiratory clinics is the most recent example of that, although in the end they managed to do it, which is great. but highly suspicious of government funding, and the hospital public health system is a bit reluctant to use MBS funding the way they could or should. So yes, that's and a key factor is obviously workforce retention in certain areas. So one of the reasons to have a better integrated, more robust service is actually to address workforce issues. GPs, private practitioners, other healthcare professionals will be more attracted to a service that can actually display a full range of other services that connect with it. So we did a work in South Gippsland where we interviewed all the providers, a lot of the providers in South Gippsland, public and private, a lot of GPs. And, you know, we found just what I said to you a minute ago, there's a big disconnection between a lot of the services. Although there's good relationships by and large, there's no systemic connection. And as I've said, public providers were good at getting grants and private providers were good at using Medicare, and there wasn't much overlap in that. Of course, ED presentations are increasing quickly, and that's a reason for more robust primary health services. Medical practices couldn't expand by and large because they didn't have any space and didn't have the support to build the space. We'll talk about that in our second session that we run. Yeah, so some towns with significant populations have little access to services. So there was a lot of enthusiasm, however, from practitioners, which is why a number of people have come today, about learning new ways to expand your services. We're not going to be able to tell you every bit of that in these two sessions. Today is just kind of an introduction to the idea of how you might be able to do that. So there was an enthusiasm for practitioners, private and public, across South Gippsland and throughout Gippsland to expand their services. And there was certainly enthusiasm for better integration and team care, but services were not quite sure how. A lot of services are doing really well in that space, but would like to do more. So why would you build an integrated model? Well, we know these things, you know, people, particularly the most marginalised, the sickest communities, require team care. A single service model doesn't work for them. And also clients, patients don't follow referrals very well, particularly marginal clients. So you've got to, building a real team that works together is really important. So, and some of the previous efforts at integration, there's a lot of talk about virtual teams. They have their place, but the evidence is that actually virtual teams are not as effective as real teams. So there's been a number of IT solutions, and we'll talk a bit more about My Health Record as we go through this, but there's been slow uptake of that and we need to improve that. So real teams that work together are a better option. Let me go to the next slide. Who's in the best practice team? This won't be news to any of you really, so I won't go through it all. But the more of these services you can have in your team, the more likely you are to provide a better quality, better services. So if you can see if there are gaps in your service that are in this team, there might be opportunities to build that team. And this is not an exhaustive list. You might have other things you think could be in there, but there might be an opportunity through understanding the funding mechanisms to build your team into a better, more robust service model. So these are just, I'll just go through these pretty quickly. A typical community health service, and this for, I suppose, community health services present and hospitals won't be surprised by this, but private practice might be surprised by this. So this is a service that Chris and I worked in, but this is where all the money came. This is how we pulled it. So what I say to the private providers present is that there are opportunities for you to access some of this revenue as well. and you shouldn't think of yourself as unable to do it. It's not straightforward, but you can do it. So, and these are the services provided by that pool of funds. So this concept of funds pooling, how do you put these resources together to build a team? And so there's, you know, quite an interest in more community managed primary health services across Australia. We've run these sessions all over Australia, and there's a great interest in how people can actually create more robust teams and get some control over them. And so the role of funders and planners, for my sins, I was CEO of a Medicare local some time ago, and we got defunded because we lacked clarity of purpose, was the story. So it's really important for funders and planners to be able to describe what success looks like. So that's a very important role for state and Commonwealth funders, and they should purchase for that best practice. So using competition to address market failure won't work. You know, there are many places in Gippsland where the market doesn't work. Population's too small, not enough providers. The need to join up public and private and NGO sectors, the lessons from COVID we've already touched on. So I won't go any further on that. So that's the introduction, the overview, if you like, about why it's important for you to grow your service. And Chris is going to go into more detail in a moment about some of where those dollars are and how you might be able to get your hands on them. So bear in mind, this is really an introductory session, and we can't answer every nuance of every question you have about your service. So maybe I'll stop there, Alicia, if there's any questions.
We don't have any questions, but we do have a little bit of what people would like to get out of this session. So they'd like some innovative ways to upgrade services and bring in further revenue. They'd like to know how to target the under 65 age group to meet their KPIs, and how to make better use of MBS, which is what you mentioned, in the allied health space, and making sure that all eligible clients are accessing the service. So I'd like some tips on that.
Yeah, cool. And Alicia will be available for follow-up following this session or the next session if people want to contact us with specific questions as well. So,
right.
So
we'll forward those details. Thank you.
So I think that's a nice segue because Chris is, as I've said, Chris's background is very much in financial management and modelling and corporate. So he understands where to find the money. So he'll tell you where it is and how to get it. Okay, Chris, I might hand over to you.
You've got to stop sharing, Rod.
Oh, I've got to stop sharing. Oh, okay.
Also, just to let you know, there was one slide that Rod missed, so I'll actually bring that up in my presentation.
You should be right to share now, Chris.
Sorry, yeah, I will.
You can share. Cool.
So what I'll be talking about is not all of the good stuff that Rod spoke about. Mine is probably a bit more dreary, and it's a lot more information. But one thing we just need to let you know is a little bit about the PHN. The PHN here within Gippsland's quite large, as you can see, and they're part of a network of 31 primary health networks across Australia. They provide a range of services, and they support medical practices, allied health, hospitals, and so forth. And they also provide training such as this. They're looking at how they can best meet the needs of our community, and also looking at how the money that they do have can be best spent within our community. As you can see, from that map, we're a very large community, and there's some very isolated pockets within our community, from Mallacoota to Phillip Island. It's a very large area that they have to fund, and there's lots of different activities that people need to do. So when I go to the next page. Okay, Gippsland PHN themselves, as you can see there, they actually fund $25 million worth of activities throughout Gippsland, with the majority of that being in the private mental health service area. They fund after-hours primary health care to various medical practices. They provide a lot of alcohol and drug programs. They do Doctors in Schools program, which is a state government new initiative. They do integrated team care, which deals with Indigenous health to ensure that Indigenous health access primary health care. As I mentioned before, half of their funding is spent in the primary mental health area. So they have a lot of activity within those areas, and they provide a lot of different providers. They also fund it through, they fund place-based flexible funding. And as the name says, it's flexible. They fund a lot of allied health services, nursing services. And I saw that Selena mentioned a question before in her note about, do we access MBS, or is all MBS funding get accessed, MBS funding being used? And we'll talk about that a bit later, but probably not, because sometimes it's easier to provide a service when you get a funded Commonwealth or state program than trying to actually fund it through MBS, which can be a bit clunky. The other one is psychosocial service. So they also support, so they also provide funding for that. The other thing that people need to be aware of is that they need to be registered to the PHN tender website, because they do a lot of tenders for different activities. And if you're looking at additional funding streams, that's one area that you can have a look at. Now, what I'll do, I'll just go back to a slide that Rod missed out on, because it actually is a bit of a prelude to what I have to do. He was looking, one of the areas that I'll be looking at is with regard to developing primary health and primary health care teams. So as this slide's got here, MBS can be one of the main funding areas within GPs, allied health, etc. And I'll give you some information about that before. People need to understand how to use MBS to make it work efficiently. As I've just mentioned, sometimes they don't use MBS because they receive a grant from the government to provide podiatry, allied health, or whatever. And you'll most likely find out that that person that you're actually providing that service to has also got a GP management plan, which allows an MBS funded service. You need to build a team around the medical practice that best works. So with regard to that is that you need an integrated team of some sort. You need more than just the GP. You need allied health workers, you need counsellors, and you need support people within that medical practice. So the GP, what they can do is that they can if they need some support from a podiatrist, they could actually just wander down the corridor and ask them a question, or from a counsellor. An organisation that Rod and I worked in Melbourne, we provided a multidisciplinary service where the GP and allied health service and counsellors would actually all work in one building. And we saw that often, where the GP would actually, if they weren't sure of something and they had a patient in front of them, they could actually just go down to the relevant service provider, if it's a podiatrist or an OT, a physio, if they're available, and ask them a question, and that worked really well. And that comes into the next point, which is a one-stop integrated care, where a person can come to a building and actually get whatever they need. And case management and coordination is essential, where you need somebody who can manage that. Rod spoke about healthcare homes and those things, and that's what that was supposed to do, but it probably didn't work that well, where it was supposed to be coordinating the care of their patient. And integrated care and utilising My Health Record. One of the thing with My Health Record is that the intake hasn't been that great, but a lot of information is available on that person's record that can help a provider when they need to see that person. So depending on the amount of information that's put there, that's a way that the service provider can understand some of the needs of that person. So if a counsellor is seeing a person for some reason, then they should be able to access some of the information that the GP's put on that person's record to understand some of their complexities. And the other one is funds pooling, which we showed you before in the diagram, where most organisations actually look at funding various services from different funding streams. So an allied health worker or a podiatrist may not just be funded from one area, but could be funded from multiple areas. I'll just go to where I was going to start. Okay, one thing I'm going to just talk to you a little about, and we mentioned before, is about MBS and MBS funding. People need to be aware of the value that MBS puts back into the economy. As it's got there was 428 million services, and it cost $24.7 billion in the 1920 financial year. So the Medicare system is a very big area. As it's got there, 8.3 billion was actually for GP funded services. With regard to Gippsland itself, just letting you know that when you're looking at the number of people, the number of times a person's been to a GP, on average throughout Gippsland is 5.8 times, and nationally it's 5.6, and this is based on age standardisation, which aligns the people to an age category to get this information. The other information we're looking at is with regard to GP attendances. As it's got there, 85.7% of the people received a bulk billed service, and then in Gippsland it's a little bit higher than that. The next slide, the next table just shows a little bit about varying the different areas, and as you can see, there is a lot of difference between different areas within Gippsland as to the number of visits and the bulk billing attendance rates. So that and that could be to do with access. So in East Gippsland, you've got Far East Gippsland, which has got probably less access to medical practices than some of the larger areas. But as you can see there, the information is a little bit different. So with regard to MBS and how it's been spent, on average, a person receives $308 worth of MBS funded services. And as you can see there, the information that we've got there, it's a bit different based on the areas within Gippsland. So Gippsland East is a lot lower, and that sort of substantiate the previous slide, which showed that people go less times, because the more times you would go, the higher that average would be. But as you can see, Borbor's a lot higher than the average, whereas all the other towns are roughly the same. And the other thing that's quite interesting is that with regard to the next lot of statistics is just the level of people that don't see a GP. So as it's got there, the average is 12.5%, but within some of our other areas, they're higher and lower. And as you can see for Borbor seems to indicate that they have a higher level of GPs than in some of the other areas, because the presentations per GP has been higher, the average they receive higher, and also the percentage of did not see a GP at all is a lot lower. The next piece of data, it just shows you the number of services that a person that are subsidised within this Gippsland area, and they're quite large. So as an example, if you're looking at GP services, so it's got the number of patients and then number of services. As it's got there, on average, a person receives about 6.3 GP services a year based on all those figures. But and also that at least 89% of the population receive a GP service. So the number of people that see a GP is quite large. And the reason why I'm talking about that is that a GP, what they're able to do is that they're able to do various things like GP management plans, mental health plans, and what that means is that if these plans can lead on to other services, other funded MBS services. So as an example, if you look at the GP mental health plan, is that within Gippsland, the levels that they're doing is about 9 to 10% of our patient population. So in theory, those 4,000 people in Wellington, they're able to receive an MBS funded counselling service. There was a question before raised, do we know whether or not all those people are getting a service? No, we don't. But as I said, some of those people may be receiving a mental health service, but rather than being funded through MBS, they're funded through some other Commonwealth or state funding stream. The other one is the enhanced primary care services, and what they are is that that's care plans, mental health plans, most of those types of things. So if you were looking at the number of those patients, again, is 11,000 patients in Wellington, then in theory, most likely can receive an MBS funded service in allied health, counselling, or one of those other different areas. So with regard to allied health services with funded, Medicare subsidised allied health services in Gippsland, this is some information that shows the services that are subsidised rather than the services that people are eligible for and maybe didn't receive. But as you can see here, there is a lot of services at the moment are being provided to the public through GP management plans. And if you look at the majority of them, they're to do with podiatry and mental health. So a person who receives a GP management team care arrangement plan can actually receive 5 funded MBS services from a range of allied health services. You could have all podiatry, you could have all physio, you could have all IT, or you could have a mixture. So one thing you need to look at is when you're looking at the figures is that, for instance, with mental health, in any of those areas, they're quite substantial. So that all those services at the moment for those patients that are shown there, they're receiving a Medicare subsidised allied health service in some way. So just following up on that, as we've mentioned there, with the services that they receive, for mental health at the moment, if a GP does a mental health plan, then they can receive 10 individual mental health services funded through MBS, and that's been actually increased to 20 for COVID up to March 21. And what they can do is that they can receive it in a range of activities like psychologists, clinical psychologists, and so forth. And the MBS payment will vary from $54.60 to $128.40. One thing you always need to think about when you're looking at providing Medicare funded services is whether or not the amount that you receive for the service will actually fund the position. So as an example, if you're only receiving $54.60 and the session could be 20 minutes or 30 minutes and you're receiving $100 odd an hour, is that enough to support that position? And that's some of the work that we're going to be doing a little bit further in this session and also in the following session. And with regard to allied health, as you can see there, they're allowed 5 visits a year, and they can be made up of various different types of service. Again, that's $54.60 for one session. So if you think that a session's only 20 minutes and you can do 2 sessions an hour, will $108 or $109 an hour be enough to fund that position? And that's something that you always need to think about. And I'd suggest that's why sometimes within the private sector, they actually do charge an additional payment for that service. So the next thing we were talking about is if you were wanting to grow your medical practice, what do you need to do? We touched on it before that medical practices don't access PHN grants. And the question is why? And I'd suggest in most of the reasons why is that they don't actually know how to do a tender, and they need support to do a tender. Some of the work that Rod and I did down in South Gippsland when we spoke to some of the medical practices down there, they were aware that there was funding available, but they didn't apply for it for mainly that reason, is that they didn't know how to complete a tender, or also they didn't have time to complete a tender. So in one way, we may need to have a look at how we actually fund some activities. So if you're doing a review, for instance, in an area like we did in South Gippsland, and we through that review, it was identified that an allied health service would be very valuable in that medical practice. Should they have to apply for a grant, or when money comes available, should that money actually just be given to the medical practice? There are a lot of questions that need to be answered when you're looking at how do you actually tender. As we mentioned before, the bigger organisations, the bigger community health services and private, they know how to tender. That's their livelihood. But a lot of the smaller practices don't know how to tender correctly for a lot of services. The other one is that they might not have any space for that person. And that's an issue in a lot of medical practices, because what they've done is that they've grown over time, and what's happened is that they're in the same building they were in 20 years ago, so they haven't got any space. So they haven't got any space to, for instance, to have a podiatrist or an OT or a physio. There's a lot of compliance costs as well associated with providing some of these other services. As I said to you before, funding through MBS for allied health services and counselling services, the system's a bit, I use the word clunky, which is
Sorry, Chris.
thing. Yep.
Isn't this a good opportunity though to develop some partnerships? Like, you know, if we've got community health services available in a local community, why don't we look at some sort of partnerships between the medical services and those other services, rather than trying to create another new service?
Yeah, I think that's a good point, Selena. And I think what we found is often relationships between the public health system and the private medical practice they varied. So yes, I think there are the opportunities for partnerships to be created. Some of the partnerships around things like urgent care centres, etc., were obviously developing. But yes, I think you're right. I think there is an opportunity for partnerships. There was a great interest from the public sector providers to actually get those partnerships going, but the how of that, got tricky. So yes, I think
it just seems that then takes away some of those compliance costs and other things.
Yes, and obviously resource sharing would be highly desirable between a public health provider and a private medical practice, but resource sharing requires a very high level of trust, or staff sharing. And as Chris said, if you want to build an integrated care model outside the hospital, or outside of a community health service in the private sector, the medical practice has got to have space to do that. And, really the overriding thing that stopped the medical practice is saying, hey, we'd love to have a physio, we'd love to have a podiatrist, we've got nowhere to put them. And we got that a lot. So, and the reason we mention that is because it comes down to the financial modelling, and the same for public sector providers as well. But public sector providers tend to have a lot better business support that allow them to open a new facility or whatever. Anyway, I don't know if I've answered your question, Selena.
Yeah, but yeah, Selena, the only thing is we always say is that we're mentioning we like to have integrated care, and I know that you can have develop relationships with community health service and so forth. But if a person doesn't have to wander all around town to get a service, it's a lot easier if they can just go to one building where they can see the OT, they can see the physio, they can see the GP. I'm not saying it doesn't happen in lots of areas, but often people can do that. And when you're looking at, for instance, because the GP can, do a referral for the person that they've just seen, the person can just actually walk in, go back to the receptionist and say, can I make an appointment with the podiatrist? Can I make an appointment with the physio? And so forth. So that if things were all in the one building, that does happen. The other area that often we found out when we did some work down your way is that the referral pathways can be a bit murky at times, and how people are referred from a medical service to an allied health service sometimes can be, the person will have a referral to see a counsellor, but they actually don't get to the counsellor. At least if all that service is within the one building or the one facility, there's more of a guarantee that that person will end up seeing a counsellor or a podiatrist if the appointment's made on that day at that particular point in time.
I think.
Yeah, but I also think, sorry, for continuity of care, if they only have 5 allied health services a year under their MBS, if they run out of those, they can then transfer across to potentially a public funding model.
Yep.
For extra services. Like, most people with podiatry would need more than 5 podiatry appointments a year. So then they're going to have their 5 MBS ones and then have to go somewhere else to get the rest.
Yeah, I think we saw that a lot. And I don't think MBS is a terrific funding source for allied health, whatever, but it is an additional funding source. So, for instance, we talked earlier about the waiting lists for public services, and a lot of those public services for which there are waiting lists actually don't use MBS. They don't have MBS provider numbers. And so the provider, usually in a state government health service, people just waited on the waiting list. Whereas if they had an MBS provider number, that would be additional form of funding and an additional way that that client could access that service. The other thing in South Gippsland, and it happens all over Australia, that we've seen is that the state government will come in and fund a service in a particular area around the corner from a very large medical practice, and there is never any thought about integrating those services. So I won't go into detail about some of the examples of that, but that then means that the chances of integrating care across those silos is actually much harder. So, this is a planning problem. And what we're talking about today is trying to really retrofit what should have been a much better integrated planned service from the outset. So none of what we're saying is really a panacea for anything, but it is a way of helping particularly public providers overcome some of their waiting list problems, and probably for private providers to start to think about how they build their team. Sorry, Selena, I've interrupted you.
All right, I'll continue on because Rod used up all my time, and I know that your time's precious. But the other thing too we've got there is that there's a lot of compliance costs, and other things that probably Selena's bringing up is that a community health service has already, got their their clinical governance arrangements in place and so forth. They're easy to develop new services. They may not want to work with the government, and as Rod said there, I did some work with the PHN on trying to entice is not the right word, but try to get medical practices to become respiratory clinics. And the thing that they didn't understand, they don't understand the funding model. So that's always the hardest thing when looking at medical practices, when they look at receiving government funding. They often don't understand the funding and the model, and they actually don't understand what they've got to provide for the model. But as an example, as I said, with regard to respiratory clinics, I did talk to a couple of clinics, and based on that discussion, they understood the modelling and did actually take up the offer of becoming a respiratory clinic. So it's more than just receiving the funding or applying for the grant. It's actually understanding how to use it and the compliance requirements as well. It's got there that there could be issues with, they've got to look at your staff management, and they need the right staff to manage that. It's whether or not they've got a throughput mentality, in that medical practices generally you get paid, it's bums on seats and you get paid. So whereas a lot of these other services, they're not as throughput driven as some of those other ones. They've had bad experiences in the past in providing MBS services or any other side, having people even rent space within their building. So therefore they've decided that all they'll do is run it as a pure medical practice. And the next one, so we spoke about medical practices, and now we're talking about public health services. So as we've got there, that they're good at getting grants, but they don't use MBS, and why? There was a question before, and I know Selena raised it, and sorry for picking on Selena, but she wanted to know whether or not we thought that the MBS was being, for allied health, has been used up to its full potential. I'd suggest it doesn't. So some of the questions, for instance, if you receive a Commonwealth funded service other than MBS, should the first question you actually ask that person, have they got a GP management plan? And if they have, then you might find out that there's another way to receive funding for the service that you're providing them. We've got also, MBS can be quite difficult to manage. The payment system, it's an online system, and it is a little bit, as we said before, clunky as to how you receive your payments through MBS, but it's getting better. It's not the same as for a GP at the moment. There could be the medical service, the community health service might be thinking it's not abiding by what its legislation requirements are with regard to double dipping and those types of things. So whatever arrangements you make with a person who's actually providing MBS funded services in the public health sector, it needs to be very clearly identified that the type of work they're doing, that the work they're doing is MBS funded, or it could be through a state or Commonwealth grant. And the other areas, they're good at managing complex funding streams. They don't see any advantage for patients. But what it can do is that rather than seeing advantages for the patients they see, they may be able to see additional patients that they couldn't have seen previously, because if they receive MBS funding, then they can move that over into another area. The next area and most of this we'll be talking about it next week, and in the next session, and it's about running your business. But these are a couple of things that people need to be aware of, and we find out that most don't. For instance, what does it cost to open up your doors before you even provide a service? Do you know how much you receive per room? So if you've got a consulting room, how much money do you think, or how much revenue should that generate? What is the cost, your actual cost to employ a staff member? I mentioned before, if you're doing allied health services and you get $54.60 and you do 2 sessions in an hour and you get $108, does that fund that position? Most organisations that we've dealt with and we've done any financial modelling for, most of them don't know the cost to employ the staff member other than their salary. Because one thing that people don't do very well is that they don't allocate their business support or overhead costs correctly across their program very well. A lot of organisations do it based on a 10%, 20% of their funding, rather than looking at what the cost is to actually employ that person and what they actually cost to employ to provide their service. Do they need a car? Do they need admin support? Do you need to send out invoices? So you need to understand how much resourcing that person needs to actually provide that service. You need to have the correct staffing skills and levels. You need to think about employing arrangements, employing versus contracting arrangements. So as before, you might have a staff member at the moment that works part-time and they would like to do MBS, provide some other services outside their hours. You could actually rent a room to them. And so in those times, they actually contract your services. Or ultimately, there's no reason why you can't even contract some of your existing services to some outside people. You need to develop a good set of business rules as to how you allocate costs and how to ensure that your IT costs or whatever are allocated correctly over the whole organisation. You need to, the other area now that's come into it is telehealth, just as an example, and the figures have changed a bit since I got my last lot of information. But since COVID has started, sorry, I'm looking it up. Sorry about this. So when you look at when COVID started, people didn't understand how to use telehealth very well. But I think as it's grown and people have now been using it now for 6 or 7 months, they understand how to use it a lot better. So as an example, there was over 30 million services being provided through telehealth during COVID. And of those, 18.8 million were actually for GP consultations. I can give you an example with regard to that. When I first visited a GP in my own area, and when COVID was first started, he was talking about how bad his medical practice had been affected, and because people couldn't come in, and he was a fee-paying practice. But as COVID continued on, and he learned how to use telehealth a lot better, he found out that through a lot of the things that he previously couldn't claim for, he can claim for now, because he can ring up a client, where in the past he'd ring one up and it would just be part of the consultation because they were there the day before. So there has been a lot of opportunity through looking at your business operations to improve your revenue or to maintain revenue as things changed. And telehealth isn't just for GPs, it's also for allied health services and counselling services. So telehealth, as I said, it's an area that's been extended, and it'd be interesting to see how that continues on. And the other area that we just need to look at is what type of business reporting do you provide back to whatever your area are. I'm just going to show you one thing, and I won't bore you too long, but this is just some information on the Gippsland region on MBS subsidised services. I know there's a lot of information here and whatever, but what people should do if they're interested in understanding the amount of MBS funded services within their area, they need to go onto the AHIW website and have a look. What this information shows here is an example, and I'll pick on Bawbaw because I seem to have picked on them for the whole session. But this information at the moment shows various levels of service that are being funded through MBS. And as it's got here, 92% of the people within Bawbaw had a GP service. 41 people had an allied health funded service. So people probably, to understand how you're going to provide some of your services and whether or not you need to provide that service, it'd be good to understand what's currently being provided within your area. And as I said, this is broken up to the same areas that's before, between Bawbaw, Gippsland East, and so forth. And the other thing which this information is helpful for, you can get it down by age group. So if you're a medical practice, and hopefully you're managing it internally anyway, but you can see whether or not all the people who are over 75 are actually having a health assessment. So this information is quite useful if you're wanting to look at expanding your services. It also shows the value in this far column of how much is being funded through Medicare subsidised services. So the only other thing I've got to say, that we're running on time for, we'll leave these questions with you, and these are things that we'll be mainly looking at in our next session. And also you'll be able to get a copy of this on the PHN website for this presentation, or else we can also send a copy out to all the people. But So what we'll be looking at in our next session is more to do with the business is just have a look at those questions. And then when we're running the next session in a couple of weeks' time, have a think about whether or not they apply to you, or whether or not after that session next week, you changed your view about whether or not you think you are doing it. Now you've decided that you're not doing it. So that's probably all I've got, unless anybody's got any questions.
Feel free to unmute yourself, anyone, and ask any questions that you might have. Rod and Chris are happy to answer those.
We've obviously answered all the questions.